I'm Dr. Jyoti Dabolkar. I'm one of the moderators, and I have a duty of introducing the panel and the speakers. So the panel today is a regional verification in oral cancers around the world. And my speakers are Dr. Neville Johnson from Australia. None of them need introduction. They are all very big giants in their field. Dr. Chin Yan Chien from Taiwan, Dr. Andre Carvalho from Brazil, Dr. Pankaj Chaturvedi from India, Dr. Golu Sinkis from Poland, and I from India, as I mentioned. So without much ado, I'll just introduce the scenario of the oral cancer in all over the world. It's the sixth most common cancer worldwide. It's a, Pankaj, take a picture. 3 lakhs new cases per year. It's the commonest cancers in the male, and 2/3 of this occurs in the developing countries, like our country and probably Brazil, and we have a largest incidences, 1.5 lakh deaths per year globally, and 50,000 deaths in India annually. So this is a huge burden of the mankind. And the incidence worldwide is depicted in that slide, and you can see that the Bhopal, which is in India, has the highest incidence of oral cancers. And these slides in itself can describe the geographical variation, which I don't have to explain. It's like it is reducing incidence, and you can see the countries here, and every country has a different incidence, and India followed by the China, and say subsequently they have a huge incidence of oral cancers. And the color in red depicts the highest incidence, and you can see the Indian counterpart, which is like completely red. All the areas in red is the incidence, very high incidence. So this is like another slide trying to show you the female incidence, and in females it is though less than the male, but it is again that it is not that uncommon, and Bhopal stands second, which is India again. So why this is happening and why we have these problems in a different incidences is basically the cultural, the habits, and probably some genetics, which will come out after a few years, that some country or some population is more prone to this disease than the rest of the world. Now in India, we have a highest incidence, as I mentioned, and it's about 9.4% of all the cancers, and these are the time of presentations of them, and 50% of them who are diagnosed die in the first year. So this is our huge burden, and probably the worst of the worst cases which we see in India. And what is alarming is, this is my last slide of introduction, what is alarming is that the age is no exempt, and sex also, as depicted before, the males are more affected than the females, is no more true. And you can see that in these slides, we have an equal incidence of, this is a 12-year-old female, and she's in 30s, and all these males are also in their 30s, less than 30 years of age. And that is alarming, that a younger age, the cancer is not a disease of a younger age, cancer is disease of the 5th and the 6th decade. And what we are seeing, and what disturbs us, is the younger generation is affected. And that is the reason why, and we all know that the oral cavity is the best model for early detection, prevention, and it is not happening. And prevention is the best cure, and early detection by dentists, by ENTs, by general physician, if we train them well, probably they can come early, and we can treat them early, and not to have a very dismal outcome of all our efforts and the resources of our country. And this is the in a preamble on which we will be discussing the topic, and I call my first speaker Dr. Noel, and he will speak about his talk. Thank you so much.
Thank you, Jyoti. You've covered all the ground already, but let's fill in a little bit more flesh. I want to talk and focus on the inequalities around the world. We've seen something from Jyoti's slides of the very wide range. We have to do away with this situation. I call it winning the fight. And we've not won this fight yet, by any means. And I'm going to be quite overtly political and think about the way we might go forward. Because we know for oral cancer that survival rates in many parts of the world are not improving, but we know the causes of most of these oral cancers, and we've failed so far to use the evidence we have to be really effective. And I want to propose to you, and there's a network already developing with other colleagues in this room and elsewhere, that we create a government task force to get coordinated primary prevention operative around the world. I'll pause till you've taken your photo. Did it work? So there is enormous global variation, and we know that the problem resides still primarily in South and Southeast Asia, and these are similar but slightly later data to the Globocan map that Jyoti showed you, and the enormous range by country in incidence and in mortality. But it comes more clearly, you saw a similar graph a moment ago, when you look at the very wide range at different countries around the world, there is a factor of 30 or 40 or more in both incidence rates and mortality rates. And you can see, if you stare at that for a while, that the death to registration ratios vary quite markedly around the world. There are indeed here enormous inequalities. And whilst we sit in fancy hotels and look at robotic surgery and improving outcomes for oral cancer in high-tech institutions, such as many of you in the room work, the reality in much of the world and in the highest incidence countries is overcrowded, smelly hospitals and wards with limited resources and advanced disease. And these are pictures from Papua New Guinea, areca nut here on the street just outside the hospital. And this is my good friend Matupi Apayo, who is the only maxillofacial surgeon in the whole of the country. And Papua New Guinea is the country with the highest incidence of oral cancer in the world, even higher than Bhopal as a nation overall. And just some examples of the fact that we haven't solved the problem. These are from a paper of ours, which, although the incidence rate, even in India, is beginning to fall slightly, with population growth, there is a considerably increased burden of numbers of cases of oral cancer in India that we will see looking forward. Just some other examples. You look at the Russian Federation, stratified by age over recent decades, and the problem is not being solved, clearly. It's static or rising, even in the 60 to 69-year-old age group. If you look at United States data, we can see that whilst the age standardized rate is projected to fall going forward in the next couple of decades of this century, the crude rate is actually rising. And that, of course, is partly to do with an aging population. And this is oral cancer we're talking about here, in which HPV is presumably playing a major role. And that situation's even worse in the United Kingdom. So around much of the world, in developed and developing countries, the burden is getting bigger. So the only approach to this that's ever going to work, because no amount of robotic surgery will reduce the incidence, we have to have a focus on both primary and secondary prevention, as well as good management, which we'll come back to at the end of this discussion. So we know the cause. Why can't we do something about it? And you all know the cause. I'm not going to spell all of these out. My colleague Saman Warner-Kulashuria grouped them rather nicely into modifiable and emerging risk factors. We know all of that. Why can't we put that knowledge into practice? And it's not just knowing down the proximal end, but it's actually upstream determinants that are things that we have to address and society has to address. And I've just come from the World AIDS Conference in Melbourne last week, and I asked myself, what lessons can we learn from control of the HIV epidemic globally? So there are 2 slides here, like you, snuck from my seat in the lecture room, which shows the fall in HIV incidence in South Africa. I picked that because South Africa, as you know, is the country in the world with the largest number of HIV-positive people. They've got that under control. How did they manage that? What are the possible reasons? And you could theorize that it's increased condom use and behavior change, improvements in the treatment of sexually transmitted infections, better early diagnosis and care, of course antiretroviral therapy, male circumcision clearly plays a role, or is it just that this is a natural history of the dynamic within an epidemic? Well, there's a lot of mathematical modeling that goes behind that, but all of those things are part of the explanation for HIV. But why did that work for HIV? It worked because society got behind the whole situation. What can we learn for those successes? Our non-communicable diseases are not sexy in the same kind of way. And what we have to do as a community is, I believe, promote the science, but open a political agenda. We've got to get laws and taxes modified to control these major causes. Where are we laying quilts out on the street? Where are people marching in anger? It was anger that drove control of the HIV epidemic. So I think there are lessons we can learn. We need to energize top-down and bottom-up for this to happen. And that is why I'm delighted that this meeting and IFNOS generated this deputation, which I hope you've all signed, to say, the date is wrong, of course, but that was wrong on the website because that's copied and pasted from the website. And as you know, July the 27th was designated. And that's a very nice description of the major points of view from both society, government, and professional points of view. It's on the website of this meeting. We don't have to stop to read it. So oral cancer all around the world is primarily a disease of the poor and dispossessed, and a reduction in social inequalities has to be part of our approach. It might, of course, well, it is true, and not so true, of course, of HPV-driven cancers, primarily in the oropharynx, which arise in the higher socioeconomic groups. So these require different approaches. And if I can just take a couple of more minutes more to look at some successes and other lessons that we might learn. In tobacco control, we've learned a great deal. The Framework Convention on Tobacco Control has helped most countries in the world reduce smoking and reduce tobacco use. We know the cost effectiveness of that hierarchy. Brief interventions by respected clinicians are extremely cost effective. I have other examples of successful outcomes, and I don't really have the time to go into them in detail, but we've developed good screening models in the community in Sri Lanka. It's very simple. Anybody can look at age, socioeconomic status, betel quid alcohol, and smoking use, and we have good predictive value in that as a screening tool. And taking that knowledge a couple of years ago in Chennai, you don't have to take the time to read all that, we wrote that declaration, which now has been overtaken, I'm pleased to say, by the IFNOS statement. There are some good examples around the world of success. I'm very impressed by what the Indian Dental Association does in its Oral Cancer Foundation. I'm very pleased that my country in the world, Australia, was the first to bring plain packaging in for tobacco products, and indeed is leading the world in immunizing boys against HPV. And There is encouragement to be taken, I think, from activities here in New York City, where this gentleman, who's a food safety representative for the New York State Department, is beginning to get legal movement and legislation movement to ban the introduction of areca nut into the United States. And that's an email, 1 hour ago was yesterday, that Alan sent me. We've got the United Nations on side now, which at last recognizes that oral health is an important component of general health. We've got the International Network for Cancer Treatment and Research very much on board. The Disease Control Network, sponsored by the Gates Foundation, is also recognizing our disease now. And the Disease Control Priorities new publication has at last managed to get oral and oropharyngeal cancer into several of its chapters. WHO Regional Committee for Southeast Asia has now got a clear policy statement to recognize the importance of oral cancer and other aspects of oral health. So several of us in the room, and we ask you to join us, are trying to build a global network which will take this forward at all levels, from government to getting the public to march. And just draw your attention that colleagues here in New York are having a meeting next September which will help us define the next steps more clearly, and I have some leaflets which advertise that for you to pick up if you're interested afterwards. So we have the background knowledge, let's make it work, guys. And now we see some examples from other countries.